Hi, I'm Howard Danenberg, and I'm going to talk to you today about a simple, easy, and spontaneous way to treat, manage, and cure turf toe. Pain in the great toe that's associated with athletics is often referred to as turf toe. It's consistent with either hallux limitus or rigidus, which is a variation on arthritis in the great toe joint, or sometimes it's just related to an acute capsulitis or an inflammation of that joint related to some type of injury. The most common type of injury that will result in turf toe is like a simple ankle sprain. Doesn't even have to hurt the ankle that much. But what happens is it has a cascading effect where the fibula becomes immobilized and the peroneus longus becomes inhibited. And that effect causes that first MTP joint to become overused. Treatment has often been to immobilize the toe joint using either a stiff-soled shoe or some type of carbon plate, because the thinking has been that it hurts to move, so let's stop the movement. However, that stopping the movement may not necessarily be the issue, because this is an entity that hurts because the toe joint doesn't move when the demand to make it move is the greatest. This causes repetitive strain. Enhancing the movement or allowing it to happen at the time that it should happen rather than restricting it becomes a treatment of choice. And if functional hallux limitus exists, or if turf shoes themselves actually cause a development of functional hallux limitus because of their cleated design, then a combination of manipulative care, shoe modification, and first-ray mobilizing orthotics become the actual treatment that is most effective. Ankle sprain is a common entity. This happens in sporting events all the time. Thousands of them actually occur a day. And it often results in the fibula losing its normal translation motion pattern. When the fibula is restricted, inhibition of the peroneus longus muscle results. And chronic inhibition of this muscle can result in pain of the first MTP joint. So the peroneus longus starts up at the head of the fibula, runs down the lateral side of the leg, under the cuboid, across the bottom of the arch, and inserts into the medial side of the foot on the plantar surface of the face of the first metatarsal and the medial cuneiform. And it holds the metatarsal down and into eversion against the ground to create support. When the fibula becomes immobilized because of an ankle injury, it can cause the peroneus longus to become inhibited. Without peroneal stabilization, the great toe joint jams chronically when you walk. In order to understand the process, first thing to do is to test peroneal strength following ankle sprain. This is fairly easy to perform, and this following video will show you how to do that.
When the peroneus longus is inhibited, it causes the foot to invert because there's no counterbalance to the posterior tibial and can often result in lateral foot pain. The muscle test is as follows. The foot is everted. The practitioner's hand stabilizes the medial side and his other hand stabilizes the lateral side. The test is to resist that inversion motion. So when you tell the patient resist, push out please, they push, and a negative test is when the muscle's strong, and a positive test would be when the muscle would be weak and the foot would invert. It's very important if the patient has sprained their ankle, or if they have peroneal tendinitis, or they have lateral foot pain, that maneuver is done gently. Because if you really try to show them how strong you are and how weak they are, you're going to really hurt them. So be careful with that.
Just make sure to use caution if there has been an ankle sprain, as testing the peroneal strength may be difficult because of the pain associated with the actual injury itself. The next part is to manipulate the ankle joint, and the following video will show you exactly how that's done.
First thing to do is to standardize the position of the foot so that you can re-examine it correctly afterwards every time. And so what you do is first just palpate where neutral is on the foot by holding two sides of the talus, making sure it's in central position. Then the knee is held fully extended and straight. Lock your knee, Terry. That's it, and that's held straight. And then with the foot in neutral, He dorsiflexed his ankle as much as possible, and you could see how limited that is, not close to the normal 10 degrees of flexion that normally should exist. So the technique for ankle manipulation is to mobilize the fibular head, which will be right here, and then to mobilize the fibular base, which is here. The reason the ankle sticks is because the fibula becomes restricted. And this is how you do that. There's several techniques for doing this. First is as follows. Terry, bend your knee, please. Patient is laying in the supine position. Flex their knee, take your hand and use the thenar eminence and place it directly behind the fibular head, right up underneath. Then you take it to its end range of motion, and you can hold the leg depending on the position you need. If it's a very large patient and you have small hands, you may want to move down here to give yourself more leverage. If it's a small, slight person, then you want to move up so you don't hurt them too much. The one thing you want to make sure is that the knee is not arthritic and can easily flex into full range before you do this. If they can't, there's a second technique, and I'll show you that shortly. So the first thing is to take it to its end range of motion, and then a really quick squeeze, and that's the first part. That's all there is to it. The second is a little bit more difficult. The knee is bent, and this would be the alternative technique to moving the fibular head. The fibular head is located directly here. The common peroneal nerve is right in the fibular notch. You want to avoid that, so you reach above and below the notch. And when you do that, you take your long or middle fingers, reach around and anchor your thumbs over the front of the tibia. And then from this position, all you do is squeeze once tight, and that usually is sufficient to flex that. The second part involves the foot end. The foot's grasped, and then traction is applied to the ankle mortise itself. Thumbs are placed directly over the talar neck, and then from the bottom you could see, move the camera down please, thank you. From the bottom you could see where my hands are located over the calcaneus. Perfect. Now, the easiest thing to do is to hold on and just lean back. You don't want to put a lot of tension on this. You just want to be able to hold it and keep it distended for a while. 30 seconds is usually adequate. Once that's done, the foot is taken to its end field position, and the adjustment is just a hand rotation down where that motion of dorsiflexion of the ankle is going to continue. So it's just like that. And then Terry will flex his ankle again with his knee locked, and the change in range of motion is fairly obvious. And that could be held, patient instructed on proper stretching technique, and then that can be maintained. And that's pretty much manipulating the ankle.
So the other aspect to this is the natural occurrence of functional hallux limitus, which really needs some type of mechanical treatment. And for this, visibly, Danenberg Orthotics are ideal because they're made with removable plugs underneath the first metatarsal head so that they can be fit to prevent any natural locking of that joint, which may be enhancing the turf toe process. The device is fit by removing the correct plug directly under the metatarsal head to allowing the first metatarsal to plantarflex and preventing the joint from locking itself. But the other problem that occurs has to do with shoe gear. Normal cleated shoe gear has a cleat directly under the first metatarsal head. And the net effect of that is that it'll actually push up, forcing the metatarsal head up and jamming the MTP joint. What can be done is that cleat can actually be ground down and removed directly from the shoe so that the metatarsal itself can actually plantarflex. And when it does that and plantarflexes, it lowers the level at which the top of the metatarsal head is and prevents the jamming of that joint to occur. So the combination of changing first MTP joint range of motion via manipulation, improving peroneal strength to change the effects of an immobilized fibula on the peroneus longus, and doing shoe modifications can actually completely change the response of turf toe and the pain associated with it.